A doctor in my masterclass came to me this week with a massive panic. She sent me a message asking, "What on earth do I do if the roleplay card says the patient refuses the medication I'm prescribing or completely rejects my care plan? Am I going to fail if I can't convince them?" It is an absolute classic question, and it is a massive trap for international medical graduates. Most doctors falsely believe that their job on test day is to force the patient to say yes before the 5-minute bell rings. So when they hit resistance, they start arguing, they start begging, and they panic when the interlocutor pushes back. The reality? OET interlocutors are explicitly trained to play difficult, hesitant, or resistant patients. If you handle this resistance using standard conversational English, you trigger an immediate timeline leak under official clinical criteria. Let's fix this right now. Here is how 90% of candidates handle a refusal on exam day. They hear resistance from the patient, they panic about their score, and they slip straight into everyday social politeness. "Oh, I'm really sorry, Mrs. Gallagher, but you really must take this medication or your condition will get much worse. Please, can you just try it for me?" Notice what just happened. Everyday social politeness tells you to apologize and beg when someone rejects your advice. But in a clinical consultation, defensive begging completely destroys your professional authority. Look at the exact technical damage you just did to your scorecard. First, you apologized for prescribing medically necessary care, which signals uncertainty to the assessor. Second, you used persuasive, desperate language. "You really must. Please try it for me," which violates professional boundaries under clinical communication criterion C3. Third, and most importantly, you stopped managing the consultation. You allowed a single, predictable objection to drag you into a 2-minute debate, bleeding precious time directly off your 5-minute clock while achieving zero progress. To secure your grade B or higher, you do not fight the patient, and you certainly never apologize for offering clinical management. Instead, you deploy the consultant pivot. When a patient says, "I'm not taking those pills," your goal is not to win an argument in minute 3. Here is the secret. OET assessors do not grade you on whether the patient agrees to take the drug. They grade you on how clinically you manage non-compliance. Your protocol is strictly threefold. First, you validate their autonomy immediately, without apologizing, which neutralizes patient hostility on the spot. Second, you isolate the root objection in under 10 seconds. Is it fear of side effects? Is it a swallowed pill size? Is it cost or a previous bad experience? Third, once isolated, you pivot straight into shared decision-making under OET criterion C5. You don't fight the patient's resistance, you leverage the clock. Here is the exact verbatim phrase you deploy on test day. Pay close attention to my vocal cadence and the structural pause. "I completely understand your hesitation regarding new medication, Mrs. Gallagher. To help me find an option you feel comfortable with, could you tell me what specific concern you have about this prescription?" Let's break down the phonetic and psychological mechanics of why this works so effectively. First, the validation. You acknowledged her hesitation cleanly, showing empathy without taking a defensive stance or losing clinical authority. Second, the targeted probe. Instead of asking a broad question like, "Why don't you want it?" you used a controlled probe that forces the interlocutor to give you a single specific reason in 5 seconds flat. Third, the consultant drop. Listen to my pitch on that final phrase, "about this prescription." It isn't a rising, hopeful, or pleading inflection. It is a firm, controlled, downward pitch drop. Downward intonation projects calm, uncompromising authority. It proves to the assessor that you own the room. Memorizing this single phrase will protect you if you hit a refusal card on test day. But here is the hard reality. Fixing one sentence will not save your consultation if your overall 5-minute timeline is leaking seconds elsewhere. If you spend 3.5 minutes taking a long narrative history in stage 2, a patient refusal in stage 3 will cause an immediate, catastrophic timeline collapse. You simply won't have the buffer left to explain alternative options, cover safety nets, or close professionally before the 5-minute limit. Now, I want to hear from you. Drop a comment below right now and tell me, what is the single roleplay scenario or timing snag you are most terrified of hitting on test day? Leave your answer below. I read every comment and I'll break down the toughest ones in upcoming masterclasses. Stop guessing your consultation timing under exam pressure. Click the first link in the description below right now to run my free 60-second Timeline Integrity Audit. Select the structural habits and timing slip-ups you currently experience in practice, and the diagnostic matrix will calculate your exact risk of test day structural collapse, giving you the precise steps to fix it before you step into the exam room. Click the link below, run your audit now, and I'll see you in the next diagnostic.